Hi, good morning, everyone. I'm Emma Sears, the new program coordinator here at PAR. I'm so glad that all of you could make it today, and if not, this event will be recorded. I'd like to start off by welcoming Dr. Samantha Holden from the University of Colorado, who currently practices in the Memory Disorder Clinic. She will speak about our topic today of hallucinations and delusions. I'd also like to welcome Pete from Acadia, who is sponsoring this webinar today. Thank you both for being here. We'll have Samantha Holden start out. Thank you.
Well, hello, everybody. It's been a while since I've given a talk for PAR. I'm so happy to be back, but I am Samantha Holden. I am a behavioral and movement disorders neurologist at the University of Colorado. So I see people both with thinking and memory trouble as well as with movement disorders in my clinic. So I provide that overlap so you don't have to see two different doctors for the same condition. And my practice is in our memory disorders clinic, which is affiliated with our movement disorders center at the university on the main campus. But our clinic's over in the Central Park location. So it's a nice smaller clinic with better parking. So I have given this talk a few times now, though the last time was pre-COVID, but this topic of hallucinations and delusions in Parkinson's disease, as well as in a related condition that we'll also touch upon, dementia with Lewy bodies, really does represent the core of that overlap between what is considered behavioral and cognitive symptoms and what's the movement disorder of Parkinson's disease. For a long time, we thought that Parkinson's just affected how people moved, the slowness, the stiffness, the shakiness, the balance trouble. But really, we are increasingly recognizing that Parkinson's affects so much more, not only in the body and how it moves, but also in thinking and memory, in mood and behavior, in automatic things like blood pressure and heart rate and sweating, in bowel and bladder function, in pain. So even though not every person with Parkinson's gets all of the possible symptoms of the condition, being aware of what can happen so that you can bring it up with your doctor, that you know it could be related to the Parkinson's itself, that you're not alone trying to deal with symptoms, that you're unsure of why or how they're happening, but also really importantly, to decrease the stigma associated with a lot of these symptoms. For too long, we have split what's considered conditions related to the brain itself and conditions considered to be part of the mind. Neurology and psychiatry really are one and the same, two sides of the same coin. And what I generally tell my trainees, my students and residents in my clinic is that psychiatry is just the neurology we don't fully understand yet. But the brain is the mind and the mind is the brain. So really working to bring those two sides of these conditions back together to decrease the stigma, to increase the understanding and research of these conditions so that we can treat and manage them better. So we'll talk about what are the types of hallucinations and delusions that can happen in Parkinson's disease, how there's some overlap into that related condition of dementia with Lewy bodies, as well as ways that we can manage it, both with and without medications. So I always start this talk with this painting by Octavio Ocampo, who is a Mexican surrealist artist who in his art uses a lot of optical illusions. And I use this to illustrate the fact that this is something our brain naturally does, which is seeing patterns in somewhat random orientations that our brain is primed to make sense out of things that may seem random. And this happens to all of us. It's something our brain does. So in this painting, when you look first, you see a bucolic scene with some trees, some mountains in the background. And then the longer you look at it, the more you start to see. Where you might see that woman sitting facing away with her head turned towards the screen first, and then you look at the picnic scene in the front with that picnic blanket and you see, oh wait, there's a woman down there too with her head somewhat ominously placed in that basket. And then you look even closer up there into the leaves of the trees and you see men's faces in the leaves up there. So this is something that the artist purposefully put into here, but our brains are primed to do this, especially seeing faces. And we'll talk a little bit about how and why that happens too. So today in this webinar, we're going to focus on what psychosis is. Again, a word that has been very stigmatized, used incorrectly, but what psychosis, the medical definition is, and how that can manifest, and how people with Parkinson's experience this. Importantly, there is a broad range of the severity of symptoms of hallucinations and delusions. But just because it may be more mild, or somebody may think, oh, I don't want to bring that up with my doctor, or it's not worth bringing up, it's important to recognize, to be aware, and to have your doctor on board to help support you if any of these symptoms were to come up. So psychosis. Again, the word that is used incorrectly a lot in lay language kind of brings up ideas of one flew over the cuckoo's nest or padded cells, but psychosis just means the presence of either hallucinations or delusions. And we'll talk about exactly what those mean and how they can look, both to the person experiencing them and to outward observers. But it's a change in how the brain processes reality. There's a lot of philosophizing and trying to understand exactly what consciousness is, period. We still don't know how this little 3-pound mass of jelly inside of our skulls makes us aware and makes us who we are. But something magical happens inside the brain to make us aware not only of ourselves, what's called metacognition, thinking about our own thinking, which is something that does separate us from most other animal species, is that we're able to think about our own thinking, but then in the processing of what's considered reality. And how could we be sure that my interpretation or perception of what's reality matches up with other people? So reality, it has to be defined as a community that we all agree that this is what we're seeing and perceiving. If somebody's opinion or perception of their reality differs from that community perception, that's what we consider psychosis. But there's a lot of gray in there too, in terms of who's to say we're all right and that one person is wrong. But how we're currently defining it is that if that reality perception does not match up with what everybody else perceives, then there's something different about that person's brain. This generally manifests as hallucinations, which, as we'll see, is the perception of something that is not really there. It could be in any modality that the body can sense things, whether that's visual, auditory or hearing, gustatory or taste, tactile or touch, but the brain makes something out of nothing. It's a perception in the absence of a stimulus. That's a hallucination. There can also be illusions, which are considered more mild, as we saw with that optical illusion that Octavio Ocampo made for all of us with that picture that he had painted, that there is something there, and then the brain kind of adds on to it or misinterprets what's really there. Again, it happens to all of us. A delusion is a false fixed belief that the person cannot be convinced of otherwise, even with evidence to the contrary. The brain is absolutely positive that something is true, even when it's not, and the brain is presented with evidence that it's not true. The brain is stuck. The causes of psychosis, whether it's the hallucinations, the illusions, the delusions, or some combination of all of the above, but that somewhat disconnect from the community-defined reality, are varied. Some are psychiatric, conditions like schizophrenia, for example. Some are neurologic, as we'll see with Parkinson's disease and dementia with Lewy bodies. Though again, that distinction between what's psychiatric and what's neurologic is really just defined on which type of doctor takes care of that condition. And really we're two sides of the same coin. But there's also medical conditions that can cause a psychosis. We'll learn about at the very end of the talk, delirium, and some of the triggers and treatments for that more acute confusional state. Importantly, psychosis is not a disease in and of itself, just like dementia is not a disease. It just describes the symptoms that somebody is experiencing. So it's not enough to say that someone has psychosis. You have to figure out why. What else is going on in that person's body and brain to create those symptoms? So in Parkinson's disease itself, psychosis is relatively common. Up to 60% of people living with Parkinson's at some point during their condition will experience hallucinations and/or delusions. But again, it's a very broad range of how bothersome, distressing, or severe those symptoms can be. It's more common to have hallucinations or delusions if the person with Parkinson's also has some thinking and memory trouble, whether that's the more mild form that we call mild cognitive impairment, where there is some thinking and memory change, some trouble on our paper and pencil tests, but the person is still fully independent day to day, paying bills, managing medications, driving, shopping. We call that mild cognitive impairment. More common to experience psychosis if somebody has reached a stage of dementia in Parkinson's, which is also unfortunately more common in people with Parkinson's than without. There's about a 5 to 6 times higher rate of developing dementia in your lifetime if you have Parkinson's versus if you don't. Dementia means that there's been enough decline in thinking and memory that somebody is no longer fully independent. Starting with those complicated things like paying bills, managing medications, and driving, but could progress to needing more help with basic things like getting dressed or bathing or grooming. And importantly, the trouble with those activities to diagnose dementia must be due to thinking and memory trouble, not to the movement trouble that people with Parkinson's have. So if you can't write a check and pay your bills because your tremor's so bad, that does not equal enough functional impairment to diagnose dementia. You have to have trouble paying your bills because of thinking and memory trouble. And in Parkinson's, it can sometimes be hard to separate out the cause. So really requires thorough evaluation, at least yearly check-ins with your Parkinson's specialist to do thinking and memory testing, as well as asking about day-to-day life, both from the person living with Parkinson's as well as somebody that knows them well. For a long time, we thought that the psychosis associated with Parkinson's disease, the presence of hallucinations or delusions, was a side effect of the medications that we use to treat the motor symptoms. Most of the medications that we use to treat the motor symptoms in Parkinson's disease work by increasing the level of dopamine in the brain. There are a number of chemicals called neurotransmitters that the brain uses to communicate with itself, brain cell to brain cell, as well as to communicate with the rest of our body. One of those neurotransmitters is dopamine, which does a few things in our nervous system, one of which is signify reward. So if we eat a bar of chocolate, dopamine starts to be released in our brain, and our brain goes, "We like that, give me more of it." Dopamine is also really important to grease the wheels of automatic movements. So if I decided I wanted to stand up, walk across the room, and get a glass of water, I wouldn't actively think, okay, now I'm going to push up, I'm going to take one step and swing this arm, take another step and swing that arm. That would be exhausting to think about that, every single little movement that my body had to do. So dopamine allows those fluid, automatic, easy movements to occur without my conscious control. In Parkinson's disease and related conditions, the cells in the brain responsible for producing that dopamine, which live down here in a part of the brain called the midbrain, it's right in the middle, it's a nice name. The cells responsible for making that chemical start degenerating. They start dying. We don't know why that happens. That's the million-dollar question. If we could stop that and save those brain cells from being lost, we could cure Parkinson's. We haven't been able to do that yet. But once enough of those brain cells have been lost, that there's about a 60 to 70% drop in the level of dopamine in a person's brain, that's when the symptoms of Parkinson's start to manifest. There's slowness of the movements, where things that used to be automatic and easy and just happen without your conscious control, now are harder and effortful. In addition, there can be apathy, loss of interest, lack of motivation, because that reward chemical isn't firing on all cylinders anymore. That little jolt of, I like this, give me more of it, is dulled. So to treat Parkinson's, the best we have currently is to get to the heart of that problem, give your brain back more dopamine. If there's not enough dopamine, give you dopamine. The problem is with our medications, whether they're oral, some are injected now, some go straight into the stomach, but basically all the medicines available right now to treat the motor symptoms of Parkinson's disease work to get more dopamine floating around in your brain. Whether that's giving you actual levodopa, that's in Cinemet, carbidopa, levodopa, giving your brain actual dopamine, keeping your brain's own dopamine around for longer with medications like rasagiline or selegiline, or giving you a chemical that works like dopamine in your brain without being dopamine, medicines like pramipexole. So all of those medications, the whole armamentarium that we have right now to treat Parkinson's, are focused on dopamine. So giving you back dopamine is good to get you moving, maybe give you a little bit more of that motivation. The problem is too much dopamine, if we overshoot, gives overactive symptoms of hallucinations and delusions. So on the flip side of Parkinson's treatment, where there's not enough dopamine, let's give you back dopamine. Primarily psychiatric conditions like schizophrenia, for example, usually starts in people's late teens, early 20s. They start having generally auditory hallucinations, hearing voices, telling them to do things. The mainstay of treatment of things like schizophrenia and that version of psychosis is to block dopamine. The dopamine's overactive and causing too much activity in the brain, whereas in Parkinson's, there's not enough and the brain is underactive. So when we're giving people dopamine to treat their movement symptoms, for a long time we thought, oops, we overshot, we gave people too much dopamine to help them move, and we caused hallucinations and delusions. It wasn't until more recently that we found, yes, the medications can certainly worsen or bring to the surface hallucinations or delusions, but even in people with Parkinson's on no dopamine medications at all, and there are some who their motor symptoms aren't that bad or they'd rather avoid the prescription medications, even those people on no medications still get hallucinations and delusions. So the medicines can make it worse, but it happens in Parkinson's itself, related to that imbalance of those different neurotransmitters. So an important aside here, that hallucinations and delusions are common in Parkinson's disease itself, up to 60%, but also very common, somewhat even more common, in a related condition to Parkinson's called dementia with Lewy bodies. There's a lot of misconception and miscommunication on the relationship between Parkinson's and dementia with Lewy bodies. And even among medical professionals, many doctors consider hallucinations or delusions to only be associated with dementia with Lewy bodies and not with Parkinson's. And that can lead to some confusion, some misdiagnoses, and an attempt to fully separate out these conditions that really overlap much more than they're separate. Hallucinations happen in both Parkinson's and dementia with Lewy bodies. It will not separate out the diagnosis. The only thing that does tell us if somebody has Parkinson's or if they have dementia with Lewy bodies is what symptoms came first and which are more prominent and bothersome. What brought that person to see the doctor? Was it trouble with their movement, slowness, stiffness, and/or shakiness? It's probably going to be Parkinson's. We might find that they have a little bit of trouble with their thinking and memory, but that's not what brought them to the doctor. As opposed to dementia with Lewy bodies, where they're coming to the doctor because they or someone that knows them well is worried about their thinking and memory. And then when we examine them, we find the slowness, stiffness, and shakiness called Parkinsonism, looks like Parkinson's. But the symptoms, as we'll see, that happen in both Parkinson's and Lewy body are exactly the same. The only difference is the prominence and the timing of the onset of those symptoms. Now, sometimes it can be hard if somebody's been dealing with symptoms for years and trying to remember back and say, ooh, maybe the tremor came first, maybe they had some trouble with their memory around the time they retired. It's hard to say, exactly what came when. And in those cases, it can be hard to really definitively separate out, is it Parkinson's or is it Lewy body? So we can also use an umbrella term, Lewy body dementia, as we'll see in an upcoming slide, that will encompass any thinking and memory trouble along with Parkinsonism, slowness, stiffness, or shakiness. But really, these two conditions are much more of a spectrum than completely distinct entities. So I outline here how we conceptualize these conditions in this hierarchy of trying to be as specific and precise as possible with these names for our diagnoses. Lewy body disease is the least specific term. That just means if we were to look at the brain under a microscope, we would see Lewy bodies inside the brain cell. A Lewy body is a round little bubble found inside the body of a neuron, a brain cell, and within that bubble is an abnormally folded protein called alpha-synuclein. And that alpha-synuclein is sticky, it clumps up. We don't know why it starts getting sticky and clumping in the brains of people with Lewy body diseases, but the brain tries to encapsulate it, to get it out, and it can't. And that's what that little bubble is. But the only way for us to be 100% sure if somebody has any of these Lewy body conditions, including Parkinson's, is to look at the brain under a microscope and see those Lewy bodies. Now, while somebody's alive, obviously we're not going to do a brain biopsy to see if those Lewy bodies are in there. So we make the diagnosis clinically based on history, listening to the person's story, the story from somebody that knows them well, and a really thorough examination. Looking for that slowness of movement primarily called bradykinesia. That's why the doctors have you do all these little dance moves to see how quick and automatic and fluid your movements are. We watch you walk, we feel your muscles for any stiffness, we test your balance by very rudely pulling you back by your shoulders to see if you fall down. But all of those maneuvers are the way that we try to diagnose these conditions in life. Knowing that we'll never be 100% sure, but we can be pretty confident. But the better we know somebody over time, and as we follow them and see if and how things change, we can be more confident about what the diagnosis is. But Lewy body disease is all of these Parkinsonian conditions where Lewy bodies are in the brain. The most common would be Parkinson's disease. There must be that slowness, the bradykinesia, plus one of two other things: rigidity, tightness of the muscles, where we ask you to relax and go loose and limp, and we move you around to see if your muscles are tight. And then a resting tremor. It should be there while you're relaxing, goes away when you start moving. Sometimes it's subtle, people don't notice it, doesn't bother them, but we don't even need a tremor to diagnose Parkinson's. About 30 to 40% of people don't have a tremor at the time they're diagnosed with Parkinson's. And they're the people that are missed, because the shakiness is obvious, people can see it, it makes you go to the doctor. The slowness is more subtle, but that's what's required. So Parkinson's disease is movement trouble without any thinking and memory changes, as opposed to the overarching category of Lewy body dementia, which, as I mentioned, is a broader term that includes both Parkinson's disease dementia, meaning somebody was diagnosed with Parkinson's, they were slow, stiff, and/or shaky, and then at least a year later, they started getting thinking and memory trouble, as opposed to dementia with Lewy bodies, where the thinking and memory trouble came first or at the same time as the movement changes. It's a somewhat false distinction here to separate it out by timing. Again, they're probably more on a spectrum, but this is how we use these terms in the clinic, in our research, to try to be as specific as possible. And that Parkinson's disease dementia starts as Parkinson's without thinking and memory trouble, with later thinking and memory decline. So for dementia with Lewy bodies, as separate from Parkinson's, so Parkinson's, you have to be slow, plus stiffness and/or shakiness. That's all we need. To diagnose dementia with Lewy bodies, there must be dementia, meaning enough decline in thinking and memory that the person's no longer fully independent, plus one or two of these following features: that Parkinsonism, slowness, stiffness, shakiness; visual hallucinations, usually people or small animals; REM, sleep behavior disorder, the acting out of dreams, which can happen years before any of the other symptoms come up; as well as fluctuations in the level of alertness, awareness, or arousal, where we all have good days and bad days. People with dementia with Lewy bodies have good minutes and bad minutes, where they might be really sharp and with it, and then like a light switch, they're a little bit zoned out or confused, and then they're back, and then they're maybe a little tired, and then they're alert again. But there's very dramatic ups and downs in that person's level of alertness during the day. So if we have two of these features, we can diagnose dementia with Lewy bodies. But what's important here is that all four of these things also happen in Parkinson's disease. So these features do not separate the diagnoses again. The only thing that does is what came first. So now that we have a lay of the land in terms of Parkinson's itself, its sister condition of dementia with Lewy bodies, let's get a little bit more into detail exactly what can happen with the hallucinations and delusions. As I mentioned before, the hallucinations are the presence of a perception in any modality: seeing, hearing, tasting, smelling, touching, a perception in the absence of a stimulus. So perceiving something when nothing is actually there. These can be very subtle and mild. I would say the most common thing that I hear from people, and usually I have to ask about it, people don't volunteer this because they don't even recognize it as related to their Parkinson's, is a feeling of presence. And again, we all get this, it's just a little bit more common for people living with Parkinson's, of somebody in the room or in the house with you, or maybe somebody standing over your shoulder, that you feel that presence, kind of like a ghost, that somebody's there, but nobody's really there. So that's technically a hallucination. There can also be what's called passage hallucinations, where you catch something out of the corner of your eye, a sense of movement, and you think, oh, is that a little bug that just, or a mouse that ran across the floor over there? And once you look at it, like you only catch it in your peripheral vision, but once you look, you see there's nothing there. So those are technically hallucinations. Again, happen to all of us that are human beings on this earth, just happens more frequently, more commonly in people living with Parkinson's. A little bit more obvious than the presence or passage hallucinations are well-formed visual hallucinations, usually people or animals. It might just be a shadowy figure, and you might not be able to see facial details or anything specific about the person, you just see a figure. But sometimes it is a well-formed person you recognize or a stranger, and usually they're just kind of standing there. They don't move around a lot, but it feels like that person's standing here in the room with me. And early on, generally the brain maintains the insight that that can't be real. Like that person can't actually be in the room with me. I know that nobody's here with me. But as the disease progresses, that insight that it isn't actually real can be lost. And that's where things can become more distressing for people. There can also frequently be hallucinations of children or small animals or even large animals. But in Parkinson's and Lewy body, they are very detailed and well-formed and look real. They have a lot of color or vibrancy to them usually, where they might even be somewhat cinematic. And something we also hear from people a lot, both with Parkinson's and Lewy body, is that they look out the window into the backyard or the front yard, and there may even be a whole complex scene playing out. And the person goes, I know that there's absolutely not a three-ring circus in my backyard right now, but all the details and all the different characters and the setting is all there, where the brain is filling in these blanks. The brain's working overtime to throw these images out there in the absence of an actual stimulus. So again, on the spectrum of hallucinations and delusions, the more mild being the illusions. So something is really there. It's not, the brain isn't making something out of nothing, but the brain's misinterpreting what's actually there. And this is usually visual. And the same with what's called an optical illusion, right? An example here down at the bottom, where some of you might be seeing a duck down there in the illustration on the bottom. Some of you might be seeing a rabbit. And now that I've said duck and rabbit, you might be able to switch your brain back and forth and see both of them. This is something our brain does. It does not like ambiguity. So if there is something in the environment that the brain is trying to figure out and going, what exactly is that? Is that going to harm me? Do I need to fight this or run away from it? The brain doesn't want to be unsure. So it will latch on and pick one or the other. And then once we're aware of it, we can control it and kind of flip it back and forth. And then you start to get a little bit of a headache when your brain's trying to go back and forth. But this is something we do. It just happens more to people with Parkinson's and Lewy body. Common examples, especially in low light situations, so more in the evenings when it's lower ambient lighting, where again, there's more ambiguity, right? Where the brain can't make out all the exact details of whatever it's seeing or feeling or hearing, then it will fill in the blanks. So in a dimly lit room, you catch the floor lamp out of the corner of your eye and you go, oh, is that a person over there? Or if there's a very busy pattern, say in a carpet or upholstery, or even the leaves and the trees outside, like the Ocampo example at the beginning that he used to his advantage in his painting, where the brain will latch on to those patterns, which are technically random, and make order out of it. Make faces, especially, because the brain is primed to faces evolutionarily, or figures or other things in that pattern. That's a visual illusion. Pareidolia is an example of visual illusions, where again, this is something our brains are primed to do, especially faces. From the time we are born, infant humans latch on to things that have a facial kind of configuration. So eyes, nose, mouth. Babies are drawn to that, and it continues through our entire lives. And just some funny examples here of things where they look like human faces, even though these are obviously inanimate objects. But we all do this as human beings. We like to see order in randomness, and we are especially primed to see faces. So in order to try to pull this out, now of course, we should ask about it each time we're visiting with our patients that we're working with. You should bring it up with your doctor. Don't be, afraid that it is something that indicates a different condition or that something's wrong or that somebody's going crazy. Again, we're working against that stigma. This is all coming from the brain. Number one, it's a natural human tendency to do, but number two, it's a change in brain signaling. And being aware that it may be happening is important to keep an eye out to see if anything worsens, and then also to treat it appropriately if and when we need to. So we should always be asking about it and bringing it up. But sometimes if we're not really sure, we can do a few maneuvers in the exam room. And this is an example of a test that was developed in Japan called the pareidolia test. And there are 40 of these black and white kind of ink blot cards, but we're not using these ink blots like psychiatrists do, where it's like, tell me what you see here. And they're trying to get into your deep, dark secrets based on how your brain's interpreting these ink blots. That's not what we're looking for with this pareidolia test. The only instructions on this test is, do you see a face in here or no? Some of the cards actually do have a well-formed human face superimposed, along with other random ink blots. And we show the card to the person, each of the 40 cards, face or no face, face or no face. So this one does have a face. So the person would say face. This one does not have a face. But if somebody does have more obvious pareidolia, their brain is primed to see visual illusions, for their brain to misinterpret visual stimuli, they might start picking faces out of this random thing. Down here, they might say, oh yes, I see a man, his eyes, his hair, his beard down here. And if we look, we go, oh yeah, I could kind of, see a face down there. But the instructions are, there should be a very obvious human face in this card, like this one. You should not have to work hard to see the face. But people with pareidolia, with Parkinson's or Lewy body, more primed to see these visual illusions, they'll see faces on every single card. So along with the hallucinations and the illusions, which are perceptions in the absence of the stimulus, delusions are another form of psychosis, which is a falsely held fixed belief that the person cannot be convinced to the contrary, no matter how much evidence you present. They generally have a somewhat paranoid flavor to them, that somebody's trying to harm them in some way, but not necessarily. The paranoid and the persecutory delusions are the ones that definitely lead to more discord and kind of hurt feelings within a relationship or a family. But there are different kinds of delusions that people can believe. In addition to those paranoid or persecutory delusions, there's often a theme of duplication or doubles in the delusions that are experienced in not only people with Parkinson's and Lewy body, but also other forms of thinking and memory changes, where the most common we see is that the person is absolutely convinced that someone familiar to them, usually their partner, is replaced with an identical imposter. And what we'll hear from the person is that, I know this looks exactly like my wife. It's not my wife. It's somebody in disguise. And again, that's not something that people volunteer or bring up to us. Like, they don't even realize it's actually a condition that has a name or is associated with Parkinson's and Lewy body. But it's called Capgras syndrome. And when we get down and we try to figure out why this person is so anxious or upset or is angry at the partner, and we drill down to the underlying reason, it's that they're convinced that it's not actually their loved one, it's an imposter. And it can come and go. There can be times where the person goes, oh no, I know this is my wife. Of course it's my wife. We've been married 50 years. But then other times during the day, they get more suspicious and they're, trying to call for help that, there's an imposter in our house. There can also be the inverse of that, where all people that look different is actually the same person changing their disguise. And they're convinced that this is the same person, but they keep changing how they look. There can also be duplication of the environment. The most common thing we hear is that I know this looks exactly like our house, but I want to go back to our real house. I don't like this one. I want the real house. So again, things that you'll hear that people will say to you, the person living with the condition, or that we'll hear, from partners saying, every night, they'd ask me to bring them home. And I'm like, we're home. I don't understand what's going on. But it actually is a delusion. It's that the brain is giving the wrong information. And even with evidence to the contrary, the brain's not going to listen. And so in these situations, trying to argue or to state your case or present all of the evidence, it's not going to work. It's not going to convince the brain otherwise. So as I mentioned before, the hallucinations, delusions, we thought used to be due just to the medications that we give people with Parkinson's, but it can be due to the Parkinson's itself in the absence of any medications, prescription medications. But it can be worsened or brought out by medications, especially amantadine, which is a medication that we use for gait and balance, as well as to help the dyskinesias when people get extra movements from their dopamine. Trihexyphenidyl or Artane, which is often used for tremor that doesn't respond to the levodopa. And then the dopamine agonists, ones like ropinirole or pramipexole. So I generally avoid those medications in somebody that already has thinking and memory trouble, and certainly if they're already experiencing some hallucinations or delusions. Levodopa in the Sinemet can also worsen them a little bit, generally less than the other ones. But if we're having very severe hallucinations or delusions, we should try to limit those medications as much as possible, and then trying to find that balance between treating the slowness, stiffness, and shakiness and avoiding worsening any psychosis. But other medications beyond what we use for the movement symptoms of Parkinson's can also contribute to psychosis. Many sleeping aids, including over-the-counter, NyQuil, ZQuil, Tylenol PM, Unisom, those are all medications that can worsen confusion and psychosis. Some antibiotics, certain pain medications, as well as more anxiety and depression medications. So if anybody starts experiencing hallucinations or delusions, the first thing we try to do is say, okay, what medications are we on that could be worsening this? What can we get rid of or reduce? But it's finding that balance between treating some symptoms and avoiding worsening others. And if somebody has occasional hallucinations, usually the delusions are more bothersome. The hallucinations sometimes are more mild and even pleasant. If you have a puppy that comes and visits you in the afternoon and you're okay with the puppy visiting, then we don't have to treat it. We only have to treat psychosis that's bothersome, distressing, or somebody's acting on it unsafely, calling the police because they're convinced somebody's breaking into the house, or calling 911 because they keep smelling gas, thinking that there's a gas leak in the house. There are things we can do without medications, though, to make it less likely that the brain will misinterpret or create hallucinations or delusions, keeping the rooms well lit and decluttered, because the more things around for the brain to see and latch onto, the more likely it is to start filling in blanks. Very busy patterned upholstery or rugs can also trigger the illusions and hallucinations. So simple things like, getting a slip cover for a couch that has a very busy floral pattern on it, just put a plain slip cover on it. If there's a coat rack in the entryway that the person thinks is a person every single night, get rid of the coat rack. Sometimes when the person has the insight that it's not real, but they're maybe trying to say, okay, this really isn't real. Is there any way for me to, ask and see, okay, maybe I'm not really seeing this? Asking somebody that's with them, say, you see that person standing over there in the kitchen? And communicating, in a kind but very firm and direct way, say, no, I don't see anybody, but I understand that your brain is telling you there, but I don't see it. The person can also try interacting with the hallucination themselves, try, if it is a person, talking to them or asking them questions. Sometimes focusing on it that way makes it disappear. where the brain then goes, oh, wait, I'm sorry, I'm giving you the wrong information. And I've also heard from people that carrying like a little mag light, a little flashlight, and shining the light on the hallucination also changes the way that the brain is interpreting it. And when the light shines on it a certain way and goes through it, the brain goes, oh, wait, based on how that light is interacting with this thing, it can't be real. Okay, I'll get rid of it. And then, of course, going through the medication list and getting rid of whatever we can. So as I mentioned, again, without medications, to very kindly but firmly saying, you know, we're safe, it's okay, not trying to prove them wrong or to convince them otherwise, but just saying like, I know you're seeing something, I don't see it, it must be a little scary for you. Can you help me with this? Distraction and redirection can be very effective here, where again, we bring the brain away from what it's doing, how it's filling in those blanks, and allowing the person to feel productive and like they're contributing. You know, can you help me with this? And I often recommend to people caring for somebody they love with these types of symptoms that you have in your toolkit a group of tasks that are appropriate for the person's level of impairments, where they can contribute, and it's calming, it's relaxing, usually pretty repetitive. So matching socks, you know, going through the junk mail, you know, something for you to have in your back pocket if somebody is getting a little bit more upset or focusing on the hallucination or the delusion, to say, can you help me with this? And having that ready to go to distract that person. And then if those things don't work, if it is distressing, bothersome, unsafe, all of our other techniques without medications have not worked, then we might need a medication. The problem is, as I alluded to in the beginning, the medications that are considered antipsychotics, what we use to treat hallucinations and delusions, work by blocking dopamine. And that's the complete opposite of what we need for somebody with Parkinson's. We need to increase their dopamine. So now we're going to try to give a medicine that lowers dopamine while also giving you a medicine that raises dopamine. Not a good idea. So there are many antipsychotics that are out there that are frequently used, like in the hospital, if somebody's confused acutely, as we'll see, called delirium, that can be very dangerous for people living with Parkinson's and Lewy body. These are some of the examples here that should not be given to somebody with Parkinson's disease. There are some exceptions here if we really need something, if the benefits outweigh the risks, where the person's a danger to themselves or to others, but these are not the first choice. They're not even the second or third choice. So these should be avoided. There are a few antipsychotics that are safer for people with Parkinson's and Lewy body listed here. Quetiapine, brand name Seroquel. Clozapine, brand name Clozaril, which works very well and is safe for people with Parkinson's. The problem is it has about a 0.4% risk of shutting down your bone marrow. So even though it's small, it's not zero. So every single person on that medication needs to be very closely monitored with blood draws every week for 6 months. And then we kind of spread it out, but you still need to be monitored very closely on that medicine. And then a few years ago, there was a new drug that was approved specifically for psychosis and Parkinson's disease that does not work on dopamine. It actually works on serotonin, one of the other neurotransmitters in the brain. So it was fast-tracked and approved back in 2016. It's called pimavanserin. The brand name is Nuplazid. And the thought was, because it doesn't block dopamine, it will be safe for people with Parkinson's. And it was. The problem is all of these medications that are called antipsychotics all come with a black box warning for older people, over the age of 65, especially older people with dementia, that use of any of these medications increases the risk of death, usually related to cardiac arrhythmias. So we have to be very judicious in using any of these medications, that we only use them when the benefits somewhat reach outweighing of the risks, which is hard to outweigh the risk of sudden death. But if it's a safety issue, the person's can harm themselves or somebody else in the home, or if the question is, you know, I can't take care of them at home anymore, I don't want to place them in a facility, is there anything that would help them, you know, feel better, feel safer and calmer at home? That's when we think about these medications. Importantly, some of the other medications that we use more for thinking and memory trouble can also help the psychosis. So I will often start one of these thinking and memory medicines, donepezil or brand name Aricept or rivastigmine, brand name Exelon, before trying one of the antipsychotics to see if I can get a little bit more bang for my buck there. And then lastly, I already alluded to it, but delirium, which can also manifest as hallucinations and delusions, is important to be aware of because it can be more common in people with Parkinson's or with thinking and memory trouble under stressful situations. A delirium is an acute onset, very quick decline to confusion, usually with a lot of waxing and waning, ups and downs in the level of confusion, along with hallucinations and delusions. So if somebody all of a sudden is much more confused and hallucinating or has false fixed beliefs, the next question is what changed? Were they hospitalized? Did they have a surgery? Is there a new medication? Were they recently traveling and, you know, the changes in their environment and time zones threw their brain off? Are they sick? Do they have a urinary tract infection or an upper respiratory infection? Are they constipated? Are they dehydrated? So if somebody all of a sudden is confused and hallucinating and they never were before, is it a delirium? What are we missing? What can we fix? As I mentioned, it happens a lot in the hospital, and that's why we try to keep people with Parkinson's and Lewy body out of the hospital unless absolutely necessary. But just to put it on your radar that there is a kit that can be ordered through the Parkinson's Foundation called Aware in Care. It's free, you just have to pay for the shipping, but it's kind of delirium precautions and a way to keep people safe in the hospital by trying to advocate and educate the staff in the hospital, because as I said, many medical professionals are not familiar with the ins and outs of Parkinson's and Lewy body, but to make sure any of those medications that I said were unsafe for somebody with Parkinson's or Lewy body, that you do not get those medicines, that they let you sleep through the night and they're not waking you up every hour to check your blood pressure, because that also, sleep deprivation contributes to the delirium, but just as a way to keep yourself safe, again, without adding more medications. So all in all, hallucinations and delusions are common. They are things that can happen within normal human experience. They just happen more if you also have Parkinson's disease, but it's usually pretty mild, and we don't necessarily have to treat it unless somebody loses insight, if they're bothered, distressed, acting on it unsafely. But even though hallucinations and delusions are common in Parkinson's, it's important to make sure we're not missing anything else, especially things that can be treated, like constipation or dehydration, and to advocate for yourself or your loved one to keep you safe if hospitalized or needing a surgery. And that's all I have. And I think we have, oh God, I'm right on time. But if there's any questions, I'm happy to answer. And of course, happy to always come back and talk some more.
Thank you so much, Dr. Holden. That was wonderful. Before we get started on the questions, I'm going to bring Pete back from Acadia back up to redo his little talk. Acadia had sponsored this event, so we're going to have him speak again.
Oh, thank you again, Emma, and thank you for that wonderful talk, Dr. Holden. I wanted to just say again, this is a wonderful opportunity to partner with the Parkinson Association of the Rockies to bring to you all this wonderful program and just bring awareness to the conditions that can happen along with hallucinations and delusions that can happen with Parkinson's disease and other movement disorders. And thank you so much for such a wonderful overall review of everything that patients are sometimes challenged with. And at Acadia, we just are very fortunate to work with great organizations like this. And we hope everyone enjoyed the presentation. Thank you so much.
Thank you. Okay, so again, just a reminder to do questions. You can type them out on the question in the toolbox or raise your hand and I can call and unmute you. To start off, we do have one question. If a person can't tell if they are awake or dreaming, is that considered a hallucination?
Yeah, really good question. So there's a lot of sleep changes that also happen in Parkinson's. I alluded to the acting out of dreams that can occur, sometimes even years before any of the other symptoms. But there can also be this bleeding between sleep and wakefulness, where there's kind of a gray period between somebody being fully awake. And again, we all experience that, where we kind of wake up out of a dream quickly and we're kind of disoriented for a little bit. But it's a little bit more prominent in somebody living with Parkinson's, or can be. But that kind of sleep-wake confusional state is not the same as the hallucinations or delusions. That should be when somebody's fully alert and awake. There are also hallucinations that can happen out of sleep or as you're falling asleep. These are classified as non-REM parasomnias, in the same category as sleepwalking or sleep talking. But as somebody's falling asleep, they might have a hallucination, or right as they're waking up, they might have a hallucination, but it's considered benign, very common in kind of teenage, adolescence. They're called hypnopompic and hypnagogic hallucinations. I have hypnopompic hallucinations. If I wake up very quickly, I'll see spiders on the ceiling, and then it just kind of goes away. But again, what's the spectrum of normal human experience versus when something pathological or that we have to treat? A really good question.
Okay, great. The next question is, can low oxygen contribute to hallucinations?
Oh, really good question. Yeah, so along the lines of all those other stressors on the brain, right, where if your brain's already working overtime to compensate for a condition like Parkinson's, if you add any other little stressor on top of that, can it upset the apple cart and kind of throw everything out of balance? So that's why things like constipation, dehydration, urinary tract infections can kind of tip somebody over into more confusion. And low oxygen levels absolutely can also contribute. So we hear a lot, people at altitude, you know, they'll go up to the mountains for the weekend and they're much more confused, or they're having more hallucinations. And it's not that the low oxygen causes the hallucinations themselves, it's just that it's another stressor on the brain that allows these things to kind of come to the surface a bit more. And really importantly, sleep apnea. So obstructive sleep apnea, which is very common. 15% of men, 5% of women have sleep apnea. Undiagnosed sleep apnea causes low oxygen levels, which is very stressful to the brain. And not only does it disrupt sleep, but it can also cause more confusion and hallucinations.
Okay, thank you. The next question is, after someone is on clozapine and Seroquel, what is the prognosis of the disease? What happens next?
Yeah, yep. So if we are at the point where we need one of those medications, that the symptoms are bothersome and distressing enough that we say, okay, we really need to treat this, we need to add something. And if the low dose of Seroquel first isn't enough, where we feel like, okay, we have to add on the Clozaril and, you know, deal with the monitoring of the weekly blood draws, that usually is a sign that the disease is a bit more progressed and there's more changes going on in the brain. And it's hard to separate out what's related to the underlying disease itself. Like if somebody is having severe enough psychosis, what does that mean for the underlying brain condition? And then separate from that, what's the effect of needing to be on these medications itself? So we know that there's a higher risk of death with the use of these medications, but what's the risk from the actual medication effect? And what's the risk that the disease is just more advanced in the brain itself, therefore requiring the medication? So it's kind of a chicken and egg problem. But we do worry that if the psychosis is severe and distressing enough to really require multiple medications, and usually at that point, somebody is at a more severe stage of their dementia where they really are needing a lot of help day to day, that we might be moving towards the later stages of the condition.
Okay, great. The next question is going to be spoke by the participant. Terrence, I'm going to unmute you now. Terrence, you're self-muted if you'd like to unmute yourself. All right, we'll move on from that question for a second, but Terrence, if you want to ask again after this next question, feel free. So the next question is, how do you deal with urges such as money, eating, sexual?
Yep. So somewhat related, but kind of a separate topic of compulsive behavior or impulsive behavior, which can also be related to that dopamine dysregulation. So there's not enough dopamine, so that reward signal is downplayed. And then we give extra dopamine and sometimes we overshoot, and there's more of that reward need or push where people can gamble or seek, sexual activity outside of their relationship, or shop, or kind of compulsively reorganize things. So that more compulsive behavior is a little bit separate from the hallucinations or delusions, but it's still mediated by the dopamine in the brain. And it is most brought on by those dopamine agonists medications, so pramipexole, ropinirole, rotigotine, the new pro patch. So if somebody has more of a compulsive tendency, if they were, gambling or overusing any substances, and especially for younger men with Parkinson's, we will avoid that whole class of medicines because it very commonly increases this compulsive behavior. So the first thing is to get rid of any medicines that may be making it worse. And then if that's still not working, it's sometimes a combination of adding additional medications, sometimes more antidepressants, sometimes some of these antipsychotics, limiting access to finances and things like that. But that can also be very difficult to deal with, but kind of a separate topic from the psychosis.
Great. Those are all the questions in the chat. Terrence, were you able to unmute yourself?
Okay.
Okay.
Is that?
Yeah.
Okay. Yeah, my question is, I have the delusions, or I mean, what you spoke about, I can relate to, except for when I experience it is at night in bed when I'm asleep. I don't really, I've got people who visit me, I just call them visitors, Every night the dreams, my husband says they're dreams, and so, but it's the same dream characters, the same dream scenes.
Yeah.
But, in the daytime, when I'm out and active, I don't see things or,
Yeah, but are they like very vivid, colorful, kind of?
Oh, yeah, at
dreams?
night.
Yeah. At night, sleeping. Yep. Mm-hmm.
The whole cast of characters, yeah.
Yeah. Yep. And that's generally how I'll ask people. So vivid dreams are definitely very common in Parkinson's too, can also be worsened by the medications we use.
Okay.
But pleasant, and not scary or nightmares or anything. So
Right.
have to think about it. But then when I start asking about the hallucinations as a way to kind of segue into it, I'll often say like, okay, any vivid dreams, nightmares, how's your sleep? And then I'll say anything like dreaming while you're awake, maybe seeing that aren't really there. So I'll use that kind of as an entree, to open the conversation. Because again, normal human behaviors, it's just sometimes the brain is sending the wrong signals, but there doesn't seem to be an association per se between the vivid dreams and hallucinations while you're awake, though we do grade them on a spectrum sometimes where we'll kind of watch and say, okay, you're having very vivid dreams. Are you starting to notice they're bleeding over to your wakefulness at all? And they don't always, but just as a way for us to.
Yeah, and I definitely have a lot of that, seeing faces and things.
Yeah. But
I can see some great pictures.
Yeah, thank you. Yeah, but it is really interesting trying to figure out how and why the brain does this, because there does be a connection between dreams and like, what are dreams? Why does our brain do this? And then why does sometimes the brain kick in these pictures while we're awake? Yeah, very interesting.
Yeah, I mean, sometimes sleep can be so bad that I don't want to go to bed at night. It's like I don't like my bedroom anymore.
Yeah. So if
and
it's
that becomes problematical.
Yeah, like if it's something that's affecting your quality of life, then bringing it up with your doctor, because there are sometimes things we can do to try to quiet those down a little bit. And of course, making sure none of your other medicines are making it worse. But
Right.
yeah.
I do take propranolol, like 12.5 milligrams at night. So I'm wondering, maybe I should
Might
get
need to
rid
move
of
it to
that.
Yep. Yeah, great. Well, thanks for coming.
Thank you.
Thank you, Terrence. We have one more question. What do you think of someone being put on Seroquel and Nuplazid?
Yeah, really good question. So because Nuplazid or pimavanserin is still so new, I think we're still kind of getting our bearings with how and when to use it. Right now, it is somewhat restricted due to cost. It's hard to get it and hard to get insurance to cover it. So generally what I do is I still start with the quetiapine because it's cheap, it's old, I use low doses. I will often give it at bedtime so that I can use, again, a 2-for-1 there where I can help the psychosis as well as help people sleep through the night and to get a care partner a good night's sleep too. But if the quetiapine's not cutting it, what I'll often do is add on the pimavanserin to the quetiapine. And if that works better, I'll often pull off the quetiapine after. But I'll still usually start with the quetiapine because it's cheaper and it's easier and it helps with sleep too. But if it's not enough, I'll often add the pimavanserin, see how we do on both of them, and then see if I could get rid of the quetiapine. But it is okay to use both. It's not, ideal per se, like we want the fewest medications as possible. But if you need more help, then we kind of have to do with what we have right now.
Okay, great. We have one last question and then we'll wrap up. What are the side effects of taking nortiapine 50 milligrams antidepressant daily at night to mitigate migraines?
Oh, I've never heard of quetiapine for migraines. So 50 milligrams of quetiapine is a low dose. There are many people that use quetiapine for depression, especially depression associated with insomnia, even if they don't have psychosis at all. So if they don't have Parkinson's, if they don't have schizophrenia or bipolar disorder or depression with psychosis. So it is a commonly used medication and it does help sleep. I wasn't aware that it's used for migraines. In migraines, we kind of try anything because everybody responds a little bit differently. But as long as it's well tolerated, that there's not a kind of hangover or grogginess feeling in the next morning, there's not bad dizziness or upset stomach, those types of things, then usually it's pretty well tolerated. That's a low dose. Usually below doses of around 200 milligrams a day, it's pretty well tolerated.
Great. Well, thank you so much, Dr. Holden and Pete and Acadia for coming by today. And thank you all for joining us today. This presentation will be recorded and placed on our YouTube channel. So you can all access it there whenever you'd like and share it with anyone. With that, our next presentation will be on July 21st with Mary O'Hara speaking on loneliness in Parkinson's. And I hope you can all be there. Thank you so much.